So that's a lot of information, a lot of useful information. I almost want to transition to like a lightning round thing.
Yeah, go ahead.
And actually, the lightning round, actually, the first thing is going to have to do with the statins and the increase of Lp(a). What are your thoughts about that?
I'm so glad you asked me that. Because atherosclerosis is an ApoB-mediated disease. It's cholesterol in the artery wall. But if you've got the genes that make apoprotein(a), X percentage of your LDL population are going to be Lp(a) particles. So you should be measuring Lp(a) in molar concentration. It's nanomoles per liter. If it crosses 50 nanomoles per liter, you enter the world of Lp(a)-mediated risk. At a level of 125 nanomoles per liter, you enter the world of, wow, you're in big trouble with Lp(a). That's 125 nanomoles of Lp(a) particles. If I took that same person now who has an Lp(a) of 125 and I counted the number of LDL particles that don't have apo(a) attached, there's an easy way of doing that, I would find it's 1,800 to 2,000. So, okay, so I don't want you to have an Lp(a) of 125, but I sure as hell don't want you to have a regular LDL particle count of 1,200, 1,500, 1,800. So I'm going to give you a statin that may, in X number of people, increase the number of Lp(a) particles. We now know how it does it, but we can get to that if you want to. But if I give you a statin, probably a rare instance, I should actually repeat the Lp(a) to see, are you one of the ones? So if you have an Lp(a) of 125, I may increase it to 130 to 150. But your LDL particles without apo(a) attached, I've reduced from 1,800 to 2,000 to 1,000. Drastically lowered your cardiovascular risk. So the trivial increase in Lp(a) particles is abrogated by the drastic reduction of non-apo(a) carrying LDL particles. And that's why the few trials we have where they actually looked at Lp(a) and people on statins, and the Jupiter is the biggest trial that looked at that. They looked at their people with abnormal Lp(a), and they lower on statins, rosuvastatin or placebo. And in the people with Lp(a), the rosuvastatin reduced MACE. It didn't reduce it as much as it did in the people who didn't have Lp(a). So what we say is the statin reduced residual risk, unfortunately not as bad as the people who weren't gifted with Lp(a), but it helped you. So statins worked. Despite the fact in Jupiter, it raised Lp(a) particle concentration.
Gotcha.
So if we're on the camera right now, it increases Lp(a) that much, and it drops normal LDL particles.
So it's an issue of just degree.
It's like the statins raising glucose. At the end of the day, they reduce heart attacks, but there's a little, you wish they didn't raise glucose. I wish the statins didn't raise LP. In most people, it's a trivial raise that is of zero concern. The internet frauds use this as a way why you shouldn't use statins. It's ridiculous. Statins help people with it. Any guideline that you pull out now says if you have an Lp(a) that's in the at-risk concentration, after you've done whatever lifestyle, if your LDL-C is still high, ApoB, I'll prescribe a statin to lower LDL cholesterol. That's the first guideline-suggested treatment for Lp(a). And look, to that you can add ezetimibe, you can add bempedoic acid, but and you better be rich because your third-party payer isn't going to pay for it because there's no FDA indication. The only drug we have nowadays that lowers Lp(a) by preventing the synthesis of Lp(a) particles in the liver is the PCSK9 inhibitors at 25% or so lowering. So should you take a PCSK9 inhibitor? Yes, if you need to get ApoB control. If I had high Lp(a), personally, I would be taking a PCSK9 inhibitor, but maybe I can afford it. Whereas the run-in, it's $6,000 a year that you're going to have to pay for it.
So I'm actually an educational question about patient, and we actually talked about this before on the video today. The concept of hyperabsorbers, we kind of briefly ran over it. And I'm thinking about an individual in my head who cholesterol, if I remember correctly, 280, 300s. reacted poorly with statins, reacted poorly with the Zetia, couldn't tolerate well-call. So went through the list of things. Have not gone down the PCSK9 rabbit hole with her. Did massive dietary changes. We actually did measure her phytosterol levels. And that was, I think it was Boston Heart Labs, I think was.
Yeah, they're pretty much the only one doing it now.
It was a little bit of a hassle to get. She did it herself, went to the website and all that kind of stuff.
Yeah.
It's a little difficult.
If you're not affiliated with that lab, it's tough to get the results.
So, because we're affiliated.
By the way, there is Empower DX, a company that uses direct-to-consumer.
Okay.
They will mail you a lancet and a minuscule tube that you have to put like 4 drops of blood in, and they take that and they send it to Boston Heart, and you'll get the exact same sterol panel.
So I can
Empower DX, Google them.
I'm familiar with it actually. So they'll do that.
They have a cholesterol panel that looks at the sterol markers.
Oh, okay. Do you have any idea what the cost of that is?
$99.
Oh, okay. Well,
Yeah, so it's
cheaper than the insurance thing. Yeah, Empower
So,
DX.
and look, if you had to pay cash for the Boston Heart Labs, it's probably more than $99.
Correct. Yeah. I'm not going to quote the numbers in my head because I'm not 100% convinced about it. But anyways, this individual got it to like 170, 180 with an incredibly restrictive diet. Yeah, just crazy restrictive diet. So I'm kind of thinking, okay, we've tried a lot of other things. You know, she has not done a PCSK9 right now. But one of the things is now this individual is almost malnourished. And so I'm at the page where it's like, okay, you've got no diabetes, no blood pressure, no other risk factor. We're just treating numbers. And it's one of those things where it's like, is this individual, by restricting their diet so greatly,
Now,
is that
remind me how old this patient is?
She's in her 60s.
Okay, so at an age group where somebody could have atherosclerosis, especially if
It's gonna be 58 to 60. It's 58, 58.
Have
Yeah.
you done a coronary calcium or any other imaging?
Yeah, we did CAMT as well.
And
It was fine.
so 0 CAC
Yes.
and even carotid, no carotid.
Yeah, we did a CMT and as well as ultrasound. The CMT showed her vascular age and her chronological age were within like 1 to 2 years.
Yeah, so look, to me right away, that tells me in that 60-year-old woman with a CAC of 0, and I put more weight on that than I do the IMT, but mostly because there's more data on it. You've got at least 10 years to worry about an acute coronary syndrome, so you got time to play. So what if whatever I was doing nutritionally was making her malnourished, I'd back off of the nutritional advice I'm giving her. Maybe you're restricting saturated fat or something too damn low. Even cholesterol in the diet, if she's not a hyperabsorber, restricting cholesterol in the diet is a total waste of time. So I wouldn't use that. That might be in somebody, if she's not a hyperabsorber, where giving a phytosterol or better yet a phytostanol supplement would help her. Lactobacilli, which reduce cholesterol absorption, would not malnourish her, but at least could. And even in a normal absorber, if you've measured sterols and she didn't have hyperabsorption, reducing absorption will make the liver grow more LDL receptors that might help you lower ApoB. If all of those drugs you said she didn't respond, now I want to know, is that because of side effects or because of lack of efficacy?
Side effects, muscle aches, pains, fatigue.
So then I don't know what the hell to tell you. But if a patient comes back and says, I can't tolerate this drug or that drug, you pretty much have to leave them. You can't force a drug down there. They won't take it. So you're fooling yourself if you... So I don't know what you tell somebody like that, but I would back off on the diet to malnourish them, especially if I knew I had 10 years to play. If she had coronary plaque to that degree, I'd let her know. And what would your life is in your hands.
And what would you consider, like, your composite scores are 0 to 100, 100 to 400. Would you say a score less than?
There was a nice study probably 2 years ago that came out that says, you are in the same risk as somebody who's had an MI if your coronary calcium enters the 300 range. So that's the nightmare range. But as a preventive lipidologist, and I'm not a cardiologist, but we have the American Society of Preventive Cardiology, to which I belong. I do even those type of cardiologists look for primordial prevention, which is what she would be. Ugly cholesterol metrics, ApoB metrics, where we probably should lower it, but we have 10 years to lower it. But therefore, any coronary calcium being positive would tell me I don't have 10 years. I don't know if I have 8 years, 5 years, 4 years, or 2 years. What I might do in that person is progress to a CTA with the Clearly studies where they can see non-calcified plaque.
Okay.
And regardless of whether you have calcified plaque or not, you can not only see non-calcified plaque, but you get estimates on the vulnerability of that plaque. So it's a little bit more imaging. Costly, your third-party payer isn't going to pay for it, so you're talking a few $1,000, especially if you want the Clearly or something rather than a regular CTA. So there are more advanced imaging things you can go to if possible that might twist your arm. I got to get a drug in there.
Yeah, I think locally, I guess we lost power here. I think locally, insurance will pay for the CTA aspect, and the Clearly evaluation is like $600 or $800, I think, to get it.
So you know that more than I do.
Yeah. That's a good point. And I guess just for the audience, because Clearly, I think Dr. Tia mentions it in his stuff. I think it's part of his thing. So
we use it a lot, but we're actually experimenting a bit now to see what we are learning from it.
Well, why don't you tell us a little bit about that? 'Cause that's something that we have available here in the Richmond area that I've had a few patients ask me about.
It can give you other parameters of blood flow through the arm, and fractional blood flow through either a true blockage or a dysfunctional blockage that is impeding blood flow. So if you have a little bit of a plaque and X amount of blood should be flowing through that, at a certain point where that fractional flow diminishes, and there are numbers that tell you, that's no good. Then you better do something about this. Now, it doesn't mean you need a stent or anything if you're asymptomatic, but it would call for more aggressive lipid management. So you would look at that's pretty much the main parameter of the reporting.
And my understanding as well, it also gives you a little bit they'll tell you about the wall thickness. So you might have an opening, it's clear, but then you might have a thickening until you've got some degree of...
Yeah, and the one problem with that in my mind too, and Peter Libby gets into this in all his inflammatory discussions and everything, is yes, we have plaque and we have plaque erosion and plaque rupture, but there is something called the plaque erosion, which is a plaque that doesn't extrude into the lumen. And that may not even be associated with a lot of lipid abnormalities, but it's close to the endothelium, and it causes erosion of the endothelium, which exposes the blood flow, mostly the coagulation system, to now the surface of that intracellular plaque. And it can induce a lot of hemodynamic changes, spasm, and also perhaps even clotting. And I don't know how you diagnose erosion, and I don't think that clearly tells you much about that. Now, that's a minority of plaques. Most of the plaques are you're going to see them, and they're dysfunctional, they're going to rupture and cause.
So back to the coronary artery calcium, because I get people, and unfortunately sometimes, and it's which cardiologist do your patients see, right? So,
big time.
Yeah, so the patient's 65 and they have a calcium score of 40 or 50. I'm kind of well, that's actually kind of low for your age. And then they see the cardiologist and they're like, oh my gosh.
It's low for a 60-year-old, but if that was a 35-year-old, that's a 99th percentile.
Correct. Well, it's all, that's devil's in the details, right? Totally, And so do you have a particular paradigm? Because you mentioned with this one individual I'm thinking about, score of 0, you're you got 10 years. So let's say you're in your 55 to 65 range. What calcium score would you think of okay, we've got 8 years, is it less than 40, 30? Is it going to be?
Look, in the real world, I'd have to make the decisions you make. And it's age dependent. So rather than the absolute, you look at what percentile they fall in, what Z-score sort of is their particular parameter. And the higher the percentage, the more likely I'm going to, I don't know if I got 10 years with you in it, I'm going to treat it.
So you're going totally off the report proper, because it gives you those numbers on the report.
And then look, this comes down to what we've always called the practice of medicine. Sooner or later as a doctor, you've got a lot of information, but you're going to have to make a darn decision, for God's sakes, based on your wisdom, your years of experience. It might just be an educated guess in some instances, but it's better you have an educated guess than their neighbor has an educated guess. So we have to do that sometimes. So we use numbers like that. If you're in a practice that is 100% devoted to longevity, and not only longevity, but when you reach old age, you have health span. So you have none of the chronic diseases, and you can enjoy longevity. You pretty much, I know Peter has said it on podcasts, if you listen to some of his Instagram nightly 30-second to I don't know what they're called on his posts on Instagram. He gives some good stuff there. Peter looks at it like if you had somebody that had a bacterial infection, you eradicate that pathological bacteria. He thinks ApoB is causal at a rather low concentration. The Mendelian study showed if you have hypo-beta-lipoproteinemia, you don't get atherosclerosis. If you've already had it, you regress it and have a far decrease in MACE. So he's of the belief you eradicate ApoB. So if longevity and health span is what is in your binoculars, you're treating ApoB if it's a little bit high. And that would be if you have Lp(a) above 60, maybe if you don't have Lp(a) or terrific other risk markers of that, you can live with an ApoB between 80 and 60, but you'd like it to be a lot closer to 60 than 80. So that's what a longevity practice might do. Longevity practice that's written the New York Times bestseller book on how to achieve longevity. But for run-of-the-world physicians where you do have limitations on what you can prescribe and course on what you can prescribe, maybe your ApoB, you live with a little higher ApoB, or do you use different levels of ApoB? But if I have any calcium score, I want your ApoB at least a bit lower than what it is. And that's presuming you don't have Lp(a), because if you have Lp(a), I don't care what your calcium score is. And there are studies showing that Lp(a), although it's a terrible calcifier of your aortic valve, it doesn't correlate that much with arterial wall calcification. So be careful not respecting Lp(a) despite a pretty good coronary calcium score.
So the Lp(a), the primary risk is with aortic valve calcification, not coronary artery calcification.
Yes, you can get calcified arteries, obviously, but you can also have non-calcified arteries with high Lp(a). So just be careful saying, oh, your CAC score is 0. I'm not worried about your Lp(a).
Okay, I got you. In that context, not in the context of overall cardiovascular disease, in the context of a 0 calcium score. Okay, fair enough.
So look, I think you're going to live with certain amounts of calcium score where you're not throwing a kitchen sink of therapeutics at somebody, but you're going to watch it. The danger gets into repeating coronary calcium. I don't think we know what that means, especially if you're on a drug. We know statins can increase coronary calcification, but reduce MACE. So should you even be doing CACs again? And there are articles written that, but you don't mind a little bit of an escalation, but if it's really going high. And the worry is if you see calcified plaque, you're missing the vulnerable plaque that goes along with the calcified. So I wish we had definitive answers on any of these. We don't. And this is why it comes down to the beauty of practicing medicine in an intelligent way and making decisions through other information.
And looking at other labs and other stuff. It's not just simply treating numbers or treating a patient.
You mentioned part of my career was women's health and big time, in fact. That gets even more complicated as a woman approaches perimenopause or postmenopause. It even gets problematic nowadays if a woman decides, I want to have children. You better be doing serious metabolic and lipid evaluations before she decides to, let's create a little embryo. Let's know what my cardiovascular, where the embryo is going to live for 9 months. It's better to live in a metabolic healthy woman. So you want to check a lot of things, ideally before pregnancy occurs. If not, ASAP, as soon as pregnancy occurs, you look at a lot of stuff.
I can correct. We actually do that when patients come in for pre-pregnancy preparation, and we'll do a bunch of metabolic stuff and nutritional.
Look, to be honest with you, when somebody becomes an adult now, and a woman, of course, they can conceive long before they turn 21. I think guys, late teens, 20, 21, by then they need their initial lipid panel and an Lp(a). And that's a good start, of course, with a blood pressure measurement and a waist size measurement. Then you're off to the races.
I tend to like do those things, to be honest with you, when I see kids before they go to college. Because my thing is like,
I'm high-fiving you with your approach.
For the average American, unfortunately, this is as good as it gets. You literally, and you're senior in high school, it's only going downhill from here. Unfortunately, I tell them that. So let's check your cholesterol now, and I'll see you in 4 years. Check your numbers, check your A1C, check your a bunch of things, and we'll see how college did for you. I was the best health of my life at the end of college, which is not normal. And so
And you know that we have done enough autopsy studies on young soldiers and even non-military people who've croaked early. And on autopsy, my God, look what's in their arteries.
Yeah.
They weren't going to have a heart attack next week, but within the next 10 years, they probably. So that's what it takes decades to build up. But if you got the risk factors and you're 20, they've had 2 decades to screw up your arteries. So the sooner you look, the pediatric societies want a lipid panel by around the age 8 or 9 to rule out FH. I would say if you're doing a lipid panel, do an LP little A, though you're not going to act on it in a pediatric range group, but somewhere in your teenage years.
So this is a question I know someone in my community is going to ask me, so I'm going to ask you this question. Like that recommendation only was in the last couple of years when PCSK9s came to market.
Say about 10 years, where what age you should start lipid screening. Now, lipid treatment is going to just pretty much apply to homozygous FH or maybe severe heterozygous FH. And if, God forbid, your kid has that, you belong in a specialized lipid clinic that deals with children.
That's a different story,
We're talking very different therapeutic approach to that.
I don't personally think I've actually seen a
most
patient
people
with
in their
that.
lifetime would never see that. And in fact, if you're doing good family histories, mom has FH, heterozygous, and dad has it, they should both be going to a lipidologist and a geneticist before they get pregnant to genotype them. What are you going to pass on here? What are you not? Sometimes they only discover their own FHs when the kid gets a heart attack at age 8, but it's rare.
And to jog my memory, like for homozygous and heterozygous, and this is, I realize, is the general question with the cholesterol numbers. If someone has a cholesterol of over 400, like what are the numbers? I have some gray stuff in my head that you can think, oh my gosh, this person probably is homo versus heterozygous versus.
Again, it's a really poor marker because you really have to do more advanced testing. Yeah. And look, if the LDL cholesterol is above 190, you at least might be familial hypercholesterolemia. Okay. Step 1 is to rule out secondary hypercholesterolemia, severe hypothyroidism, kidney disease, certain liver diseases, which should be obvious.
Standard,
Then the kidney disease, you'd be nephrotic with swelling, the liver disease, you'd probably be jaundiced by that stage. But hypothyroidism, we don't usually see hypothyroidism to that degree to drive LDL. They did in the old days. That's when they had myxedema and goiters that you could see from 2 miles away. We don't see that anymore, that degree of hypothyroidism. But there are other causes. There are certain drugs that can send your cholesterol through the roof, sometimes mostly prescribed by either psychiatrists for some of the psychotic disorder, or dermatologists, some of the dermatologic drugs. Yeah. But the most common cause nowadays are these ketogenic diets that in X number of people can give you what we call the FH phenotype. Your LDL cholesterol is from 240 to 400, which normally we're even thinking homozygous. FH.
I've seen multiple patients do that and see their cholesterols go to 350s.
They're the people, my belief is they have to re-examine the saturated fat in their diet. There is a little bit of evidence that if you love ketogenic diet, just do it get ketogenic by not using saturated fat, using the monogenic monounsaturated fatty acids and the polyunsaturated fatty acids. That can help you. Otherwise, you want to eliminate the saturated fat and see if your LDL cholesterol ApoB disappear. If they do not, but you believe I got to go back to the saturated fat, then either you play Russian roulette and say, it's not going to bother me, or you take a lipid modulating drug. But I'm going to tell you, if you're on one of those diets and your LDL-C is 400, we could throw the kitchen sink at you and might not get your LDL cholesterol back to normal. Yeah. When you make your LDL particles humongous, and anybody that has an LDL cholesterol above 200 has gigantic, fluffy, buffy LDL particles, don't assume they're innocent because they're killing FH patients right and left. When your ApoB is or your LDL particle is that big, the ApoB that it's on the surface totally changes its conformation, and it's no longer compliant with the LDL receptor. So LDL receptors is just as poor as clearing fluffy, buffy LDLs as it is small LDLs. And that's why people with FH or diabetes have such high LDL particle counts. One, it's too many fluffy buffies, and the other ones, it's too many smalls. So even that can't help you. So that's very high. But there are people out there who just say, I'm taking my chances. They do a coronary calcium. If it comes back 0, they say, I got 10 years to play with.
Yeah.
Almost all, and you probably know this better than I, but even on the little experience I've had or other, nobody stays on a ketogenic diet for 10 years. They can't.
Yeah.
It's not the world's easiest diet.
I mean, a lot of the literature and data on longevity is actually with 3 to 5 day water fasts. And so,
Yes.
so everything else is trying to,
intermittent little fast.
so we're trying to replicate
I'm a guy
that.
who lost 70 pounds with an intermittent fasting 5 days a month,
Yeah.
and the rest of the month sort of a hypocaloric
Yeah.
diet, low carbs, and I lost 70 pounds like
Yeah.
that. And it turns out it was probably just the hypocaloric for a guy like me who was eating tons of calories. I don't know, the intermittent fasting, did that contribute? I mean, the debate is still on in that, so I don't know. But I do know this, I was religious with that for 4 years. But even me, who knew the consequence, after 4 years, you just start slipping, and before you know it, you're on that road to where you were again. So that's the problem with that type of diet. Nobody wants to stay ketotic. And if you're truly ketotic, you're sticking your finger all the time to prove you're ketotic.
Yeah, I kind of did there's a breath device you can use and other things, and you kind of get the feel for it. But personally, it takes me like 18 hours before I start creating ketones. And so it's
from
like
day one, yes.
Yeah, and so you really need to be at least doing a 24-hour.
So I don't know that that's the answer, but I as a lipidologist, I worry.
Yeah.
ApoB is proven to be causal. I don't know. There are some people, as with almost any other risk factor for any disease, go through life and somehow escape the dangers of high ApoB through whatever other protective genes they may have. But I don't think you know that till you're 90 years old and you've made it.
You make
so
it.
that's why I say, that's sort of Russian roulette.
Last thing I want to ask you, and this, 'cause I know some people that I'll see in the next couple of months will ask me, why didn't you ask this question? ApoE4. So I see people who get their gene stuff done, they see that, and all of a sudden they're like, oh my gosh, it's the end of the world, right? Kind of thing. Like, what are some brief thoughts about that? Not ApoE3, or I'm calling E3, or E3,
Yeah,
like
well,
ApoE4,
I'm a believer, just like everybody ought to have an Lp(a) once in their life. In the future, you may need it more if we ever get successful therapies to attest the efficacy, but that's in the future.
Yeah.
Right now, you need one Lp.
So you wouldn't necessarily recommend repeating it and doing things and repeating the
No,
Lp(a).
two times now where we repeat it. If you're one of these statin-worried people, you want to see does your Lp(a) go up, I'm fine, repeat it, but also make sure you're repeating ApoB, and I'll tell you how to calculate non-ApoA ApoB.
Yeah.
And it's very easy. You have to know one number to convert ApoB to molar concentrations. So then I think people who go on PCSK9 inhibitors like to know, you're telling me it lowers Lp(a). So fine, we'll repeat it if you're on a PCSK9 inhibitor. But I know of no other reason to repeat it. People are now saying, hey, as you go into menopause, ApoA can go up. Estrogen is a factor that can keep ApoA reduced. So it can go up as you lose estrogen. Usually it's a 5 milligrams per deciliter variant, so it's an irrelevant. There is some variability in how it changes also. Some people go up a little higher. But I will tell you this, it almost never takes somebody who's in a low-risk Lp(a) zone and puts them in the higher. You may go into the lower parts of the intermediate Lp(a) zone, for which there's nothing we're doing about it now but lowering ApoB anyway. And if you're a nightmare Lp(a) and you go on estrogen and it goes up a little bit, you're still a nightmare Lp(a), so you haven't worsened anything. So there's that little thing. Never, ever check Lp(a) while a patient is sick. ApoA is produced in excess in acute situations. So in a really inflammatory disease or I got a sore throat. Don't be checking LP little a. And,
Have you seen gone up with people post-COVID or with COVID, or is that something you've
I
all
don't
looked
have
at?
that much experience. There's
Okay.
a lot of literature on that, which I have not taken the time
Okay.
to read. So there are interactions there, and
The immune system,
what goes
clotting and stuff.
on, and a lot of interest into the research on LP little a in that situation.
So briefly, like the ApoE4, like
So
what?
yeah, back to E4. So I believe everybody ought to genotype themselves for E4, and there's two reasons. One, whether you have one or two E4s, you are at increased risk for cognitive impairment, and not only Alzheimer's disease, but Lewy body dementia, frontotemporal dementia. Believe it or not, E4, if you're a kid who's going to play football, if you're going into the military and you get concussed more than once, way more neurologic impairment down the road. We're almost at the point where if you carry an E4 gene, your kid should not play ice hockey or football or some other rugby or even soccer where the ball is hitting. Go into some other sport, take up golf or something. So there's information emerging on that. If you have a stroke and you're at E4, the recovery can be a lot worse than if you're not E4. So there are good reasons to know that. So now you're not going to absolutely get dementia, even if you have E4. About 80% of them will be going down, but some won't. And just because you have E3 doesn't mean you can't get cognitive impairment and dementia. You're at less risk for it, for sure. E2 seems to be protective against the standard types of Alzheimer's disease, but there is a type of dementia, even E2, is rarely associated with its angioate deposits in the wall of your artery, kind of rare, angioate arteriopathy, it's called. So, but most people are not going to have that.
Is that like because I've had a patient with the beta amyloid. They actually had it's a vasculopathy with beta amyloid, and they actually
That's what it is.
Okay.
It's beta amyloid.
They actually,
It's in the,
okay, yeah. Actually, I've had one patient with that. Yeah.
Yeah, so that's something you have to watch for. E2 might be a little more. So if you have the preventive neurologist I work with, if you have E2, they're going to scan your MRI looking for certain deposits that would tell them, oh my God, you're getting that type of amyloid angiopathy.
Yeah.
So it'd be rare, but if you're a preventive neurologist, it's the type of stuff you watch for very carefully when you're counseling people on the results of it. Now, listen, E4 also puts you at high risk for hypercholesterolemia, hyperbeta-lipoproteinemia, so they're at increased risk for heart disease. And one of the reasons is, and I'm the lead author of the article that brought this to light, while at HDL Labs, we had 600,000 sterol specimens that we could look at absorption of sterols in the blood and everything. And we showed that the major causes of hyperabsorption of cholesterol that you can predict ahead of time is carrying an E4 gene or being in menopausal women. So again, loss of estrogen is involved with going from a normal absorptive state to a hyperabsorptive absorption of cholesterol. I'm not talking fatty acids or other lipids, specifically sterols. So kind of interesting. So ApoE gives you a lot of stuff. Now, the people say, oh my God, you don't want to know, you're going to dementia because there's nothing you can do about it. That was true about 15, 20 years ago. But I can tell you there have been Alzheimer's disease clinics that for 20 years have been measuring the ApoE4 genotype because they believe there's a lot of stuff you can do if you get the E4s early in life with lifestyle and even certain supplemental, even prescription medicine nowadays that would prevent the development of Alzheimer's disease. One of the things thought to be causal for Alzheimer's too is ApoB. So preventive neurologists treat ApoB with an aggressive passion in their E4 carriers or so. There's other machinations you have to watch there, but you do. So if you knew you had an E4, if you either should really assume they're a hyperabsorber of cholesterol and maybe just start with Zeti if you need a drug to lower ApoB. In the past, we were all told, well, E4s don't respond to statins. Of course not, because there's so many are hyperabsorbers of cholesterol, which identifies a group of statin hyporesponders. So if you knew ahead of time you're a hyperresponder, the statin should not be your first ApoB lowering drug. Ezetimibe should be.
So maybe an E4 with high cholesterol.
Yeah, look, I would tell you E4 and high HDL cholesterol, just start ezetimibe if you need a drug to lower ApoB.
E4 because HDL and LDL absorb together, like you said, previously, they're probably
The
hyperabsorbent.
enterocyte, when it hyperabsorbs cholesterol, it has to get rid of it. So it has three options. The intestine overloaded with absorbed cholesterol can stick it in a chylomicron, ship it out, lipidate an HDL particle, take it out of here, HDL, or resecrete it to the gut via ABC G5-G8 transporter. But you have to have functional G5-G8. Most hyperabsorbers, that escape mechanism is broken genetically. So once cholesterol gets in, they can't get rid of it. And that's why there's hyperabsorption of cholesterol to begin with. If you were doing genetic analysis on people, if you're doing it day one and you see a loss of function of ABC G5 or G8, those are the sterol exporter membrane transporters. You know you're going to be a hyper. It's, by the way, if you have just heterozygous FH and you now have hyperabsorption, you check G5-G8, you've identified another gene, you're a compound heterozygote. You got two genes driving your LDL cholesterol. And one of the therapies better be ezetimibe in such a patient. So there are interesting, that's why I believe sterol testing for everybody can really help you, especially a practice like yourselves where you're looking at things to do precision medicine.
Yeah.
Day one, knowing hypersynthesizer or hyperabsorber, if you get to the point that I need pharmacological treatment, you know really smartly ezetimibe or statin bempedoic acid. And another interesting caveat to all of that, if I went with a statin monotherapy in everybody, God forbid a hyperabsorber, statins can worsen the absorption of cholesterol. Because by inhibiting synthesis, the body genes say, oh my God, we're not synthesizing cholesterol. They turn on the absorption genes more. So that kind of information can tell. In such a case, if you're going to especially use a potent statin, you might day one go with baby statin and ezetimibe, and you'll get way more ApoB lowering. So, and many lipidologists, now granted, most lipidologists, people are walking into their office with scary ApoBs. They don't start monotherapy anymore. It's almost all statin ezetimibe day one. And I'll tell you, even most lipidologists are not measuring the sterol markers because of the complexity of being associated with Boston Heart Lab. Most of them don't know about. Even a direct-to-consumer, your patient has to do that now. It takes a month to get for them to do that, and you get the results back, you know. So,
Understood,
roadblocks. So, but you can see as you get into even better understanding absorption, you might make a little better therapeutic decisions.
Okay.
Hyperabsorbers, that's where you should avoid the phytosterol supplements like they're the plague, because not only will you absorb cholesterol, you'll start absorbing campestrol, sitosterol, and above a certain threshold in the plasma, they are toxic to your tissues, you know? So that's why I think even post-therapy, measuring of sterols provides information, but only if you understand that information. And luckily, all you have to do is read my 2 chapters in therapeutic lipidology, which totally deal with the intestine.
There you go. Sounds great. So I really appreciate your time today, dropping out here. We had a great conversation. If people want to know more about you, what are you doing? What are your, I know you said you're like you're in a great situation. You're not really retired. Like, where can people find more about you? And the other question is, what are you doing? Like, what's your next thing? Are you like just in cruise mode,
No, there's never a cruise mode in lipidology because I have to keep relearning what I used to think because it keeps changing and we're lots of, I had to rethink the whole HDL hypothesis. We got into a little bit of that today. So I had to rethink the whole reverse cholesterol transport process. I didn't know anything about cholesterol absorption until ezetimibe came around and I was introduced to the world experts who were studying that because I was in on the ground floor with that too. So there's always much to learn and relearn. But for people who, the best way to see what I'm thinking and keep on top of what I'm reading is follow me on Twitter, @Dr. Lipid.
Okay.
It's not at Tom Dayspring. Maybe you could put in a search thing, what's Tom Dayspring's
at Dr. Lipid.
Twitter, whatever they call them, you'd find at Dr. Lipid. If you're a healthcare professional, that doesn't necessarily mean MD or DO, but it could be you're a PhD researching lipids, you're a nurse practitioner, an RN, an LPN, a nutritionist, a lipid scientist, or you can ask to connect with me through LinkedIn. I try and keep it to healthcare professionals then, because I think there's a little better understanding. I can get a little deeper. And LinkedIn allows me to use a lot more words than Twitter does.
This is true.
Twitter is all graphics, which is why people really love me. Because even if you read the long paragraphs, seeing a picture sometimes makes it a lot more than this. So now look, on Twitter, my tweets, you can comment on my tweets. And if it's a positive tweet, I'm either going to like it or I may even answer what you say to, hey, I want you to think a little bit. You can direct message me at Twitter, but it better be good. It better be a serious question. Don't message me and tell me I'm an idiot. That'll get you nowhere.
Blocked, right?
You won't be getting much more Dayspring stuff. Don't worry. And of course, LinkedIn, any professional who messages me there, I will absolutely answer, if not call. So that's a good way. And look, I don't give out my email address. If you message me, I might. There are patients who are detectives, and they somehow find out my email somewhere on the dark internet. It's out there, and they even only a few of them they got. I found my cell phone number. So normally my cell phone, if I don't recognize it, I don't answer it. You would then have to leave a voicemail, and if it's intelligent, then I might respond. But if I don't see it's Aaron Hartman calling me because he's in my list now, I'm probably not going to answer the cell phone, but they get it. And if they leave an intelligent voicemail, and too often it's somebody who, it's a lipid nightmare, who I know needs desperate help. I know this is help they can't get from their local doc. Maybe they've been trying. I may interface a little bit. I'm not going to become their doctor. I don't practice any, but I can point them in the right direction.
Cool.
So that's the best way. You know, I still publish the eyeball article, but if I did, it would be tweeted. I actually get around through podcasts nowadays. This is why I jumped at this opportunity, and really so because it was an in-person, which is way more fun than a Zoom call, where you still see me, but it's sort of dark and coaching. Or it's a phone thing where you only have to listen to me, and God forbid. Even Peter in the initial 8 podcasts, we did slide notes with a lot of graphics, so that helps. So this has been great fun. So that's the way. And even if you Google me or any of the search engines, I've done so many podcasts now. Some are a lot better than others. I think this is going to be a real good one. There have been others I just did with Simon Hill. It was 2 hours alone on Lp(a). So that's like an Atia podcast down and dirty. The last thing, where am I going? Apart from still trying to help any doctor I can better understand run-of-the-mill or even rare lipid disorders. Peter 2 years ago did a podcast with one of Lipidology's superb world experts on everything, but especially high-density lipoproteins, Dan Rader. I've known Dan for 30 years, for God's sakes, one of my first mentors. He was Philly, I was North Jersey. We weren't that far apart. We met at a lot of meetings and stuff. So Peter finished his podcast by, Dan, where are you going in lipids? What's left? I mean, we pretty much therapeutically have what we need for the vast majority of non-genetic nightmares nowadays. So where else are we going? And Dan was very perceptive, as he always is. He goes, it's the brain. With this emerging incidence of cognitive and degenerative brain diseases, virtually every one of them has lipids in part of the etiology of them. So we better start discovering how lipids are manufactured and transported in the brain. And if there are lipoproteins in the brain, what are they? What do they do in the brain? Do lipoproteins have anything to do with amyloid or tau? And the more we understand, if we understood that, we might understand pharmacological approaches to correcting pathological brain alterations in lipoproteins.
That would be
so
interesting.
That's where I'm going now. I'm fortunate enough to work with a world-class preventive neurologist in the practice I am, who was trained at the Cornell Cognitive Impairment Center, where now I understand takes 3 years to get an appointment until. Trained under Richard Isaacson, the forefather of preventive neurology, who now has left Cornell, runs his own Alzheimer's clinic down in Florida. Google him. CNN did a couple of nice interviews with him over the last few weeks. and she trained under him. I've known Richard Isaacson. Peter introduced me to him, I would say, at least 10 years ago. And we started discovering lipidology in the brain together on a lot of things. So some of the things I now believe about the brain, and Kellyanne, our Neotis, our preventive neurologist, and he recognizes there are markers you can actually measure in the blood nowadays that give you some insight to the brain. And they sure as hell want to know if you have ApoE4.
Yeah.
Because they want to know when you're 20 years old. And believe me, if you see the interview he did with Dr. Gupta on CNN, you will see some of their therapeutic approaches. And even when they take people with Alzheimer's now disease, they actually improve it a little bit without using the big new drugs that you can prescribe that people like him will use here and there. But there are simpler things you can use. But I will tell you, ApoB lowering is one of those. And we'll wrap this up and invite me back another time. When you prescribe a statin, statins not only inhibit cholesterol synthesis in the liver, but also in the brain. Cholesterol, the brain has one supply of cholesterol. It makes it. It cannot get it from the plasma. That's why you can have an HDL cholesterol of 5 or an LDL cholesterol of 10 in your plasma and have no brain manifestations of that, because no brain lipoprotein enters the blood-brain barrier, shares cholesterol with the brain. So the brain has to de novo synthesize all its cholesterol.
Would that be the reason? Would that be the reason why certain, like the water soluble versus the fat soluble statins, why certain ones might have more of a cognitive effect?
Thought at one time, now known to be irrelevant. We now know if you're going to prescribe a statin, once it's in steady state, all statins get into the brain and have the ability to inhibit cholesterol synthesis. Now, for Alzheimer's disease, some degree of lowering cholesterol synthesis is very desirable. What is not probably desirable is oversuppression of cholesterol synthesis in the brain. So at a certain point, if you're suppressing cholesterol synthesis with a statin, and look, even if you look at the statin data, they're neutral on cognition, they never worsen it, and a few people, they might even improve it, but it's not randomized controlled trials where we have that data. But you can't hurt anybody with a statin, but we think maybe there's a minority of patients you can. How about the few people who get brain fog when you do prescribe a statin? They certainly a statin isn't agreeing with them.
Yeah.
Could they be the ones that day one you're over-suppressing cholesterol synthesis? To show you how much cholesterol synthesis is desired and preserved in the brain, cholesterol molecule half-life in the plasma is 3 to 5 days. Gone. Either become a bile acid or out through fecal cholesterol. In the brain, the half-life is 5 years. That means that some cholesterol molecules last 35 years, rule of sevens with half-lives. So that means once a brain synthesizes cholesterol molecule, it reuses it. It doesn't excrete it and get rid of it like we do in the periphery, what the liver and intestine can do. So that's why it doesn't need cholesterol from the plasma, because it makes its own. But now artificially, there's probably a certain point at which you don't want to stop synthesis. No other lipid drug affects lipid synthesis in the brain. So you don't have that worry with any other class.
Do you know if you were to suppress the lipid synthesis for like 10 years and then you stop the medication, does that
No, we don't know that. All we know now is there have been people who have studied biomarkers of cholesterol synthesis, and the primary one is desmosterol.
Okay.
There are two pathways that cells synthesize cholesterol. One goes through desmosterol, one goes through lithosterol. If you're doing the Boston heart, you get the concentrations of both of those. Lithosterol pretty much tells you about synthesis in the peripheral cells. Desmosterol is brain or steroidogenic tissue. They use the desmosterol path. The nice study that you can measure desmosterol in the cerebrospinal fluid, it correlates extremely well with plasma desmosterol. Ergo, measuring plasma desmosterol tells you what's going on in the brain. Because where does the CSF get desmosterol from? The brain interstitial tissue. So, desmosterol, when it's low in the cerebrospinal fluid or the plasma, associated with people who developed cognitive impairment and Alzheimer's disease. So that is pretty serious, provocative, hypothesis-generating information that maybe we ought to look at desmosterol, and people were prescribing statins to it. If we suppress it too much, maybe that's where you back off the statin a little lower ApoB with drugs that do nothing in the brain, which is every other lipid modulator.
That's actually intriguing. That could almost be another conversation.
It is. Yeah. And I told you we just did a 2-hour conversation on the proof with Simon Hill.
Yeah.
In August, it's a Zoom. He's going to interview me and Kellyanne Otis, the world's second best, maybe as good as Richard Isaacson, preventive neurologist, who know, and me, and we're going to discuss lipids in the brain and degenerative brain, and there will be a lot on desmosterol and the other markers.
Cool. That's in August.
There's one other sterol metabolite that if the brain has to get rid of cholesterol, because extra cholesterol in the brain is associated with Alzheimer's disease. So you might want to know, is there oversynthesis of cholesterol in the brain? Now, if neurons oversynthesize cholesterol, they have to get rid of it. Otherwise, the cholesterol will crystallize and kill the neurons. Not advisable to kill neurons. So the neuron is the only brain cell that carries an enzyme that the liver carries. The only 2 tissues that carry an enzyme that converts cholesterol into a hydrophilic oxysterol. Now, what are the oxysterols that the liver produces? Bile acids, which go right through the bile duct and you get rid of them. So changing cholesterol to a bile acid, really a hydroxysterol, gets excreted. The brain can convert cholesterol, which is a kind of hydrophobic molecule that cannot pass through the blood-brain barrier and escape, to a hydrophilic lipid called 24S-hydroxycholesterol. It's a bile acid that the brain produces. And the brain only changes cholesterol to that bile acid when it wants to get rid of it. Because it has a hydroxy group on both ends, it's sort of it can pass right through the blood-brain barrier, right into plasma, where it jumps on the first lipoprotein, be it an HDL or an LDL or a VLDL, it comes by. They return it to the liver, which converts it to a bile acid, and you get rid of it. So that is Mother Nature's way of brain getting rid of cholesterol.
Wow. Cool.
Change it to an oxysterol, which will make its way back to the liver. So if we could measure 24S-hydroxycholesterol, and it's up in the plasma, there's too much cholesterol in my brain, and that might suggest a therapy. If it's down, you don't find it in the blood. And by the way, almost all 24S-hydroxycholesterol in the plasma has a brain origin. Then you might say, wow, if I'm not finding it, is there hyposynthesis of cholesterol in the brain? And by the way, when you do autopsy brains in Alzheimer's diseases, there is the low cholesterol.
Interesting.
So,
well, thanks
there's so much going
thanks
on
for the insight. That's super cool. Again, thanks for coming out to our office today. Thanks for your time. Really super appreciate it. At Dr. Lipid, at Twitter. You sound like you're super approachable. That's actually how I got it. I got introduced to you from a local colleague, but I actually got a hold of you through just reaching out via LinkedIn. So again, thank you for your time. Thank you for your wisdom and your insights. It's been really super helpful.
I've had so much fun chatting with you, and maybe we can do it again on one of these sub-segments.
Yeah, I know. It's almost like, because we're almost starting another conversation, which I think is going to take us another two to 3 hours. So.
Oh, yeah. No, look, I could get way more into the HDLs, the brain. Yeah. You want to get into the triglyceride pathology, so another day.
Fair enough. Great. Well, thanks a lot for your time. Really super
Anytime.
appreciate it.